So if you could just keep yourselves on mute unless you want to say anything, that would be very, very helpful. And we're going to be finishing about 12 or just before. If you've got any questions, you can, of course, ask them out loud or use Menti. And that's why we have Menti, because we know lots of people can't use the chat box. And as usual, these sessions are for you. So we like to keep them as informal, but hopefully as informative as possible. So I'm going to go to Menti with you. Lots of people are already there. Woohoo! I like that. I can tell when Andy's in the room. Pretty sure that's Andy. Okay, so who is in the room? Seamless link. Always like to know who we've got here. We anticipate a high proportion of analysts, but we also like to know who else. Who else is in the room? Oh, I'm not health economists. Public health. Excellent.
How awesome are those health economist people?
Yeah, that's what I meant to say.
All of them deserve a super pay rise, I believe. You know,
yeah, absolutely. I don't know.
Be a VSM 3 for health economists.
I press record and all this comes out. Oh, I don't know. Yeah, absolutely. So we've got analysts, lots of health economists, which is brilliant. Data scientists, principal analysts, so analysts at lots of different levels. Somebody's just lovely. Perfect. Okay, excellent. That's great. Well, so I've split out again your role, and if you could just tell me which organisation you are from as well. We can see if we've got like a coverage of all the organisations. Let's have at least one in each. Otherwise, I'm going home. Oh, hang on a minute. I already am home. Well, there's a special slot there for health economy. There we go. There we go. It's all covered. Lots of local authority. That's great. I think local authority is the winner. Oh, CSU is close behind. Yeah, strategy unit. Okay, that's great. Thank you very much. So I won't move the slides on because I think the next slide is a question for Andy's presentation. So what I will do right now, loads of build up, I will hand over to Andy. Over to you.
That was a great build up and handover, Rachel. Thank you ever so much. And always want to big me up. So thank you ever so much, everybody. I will run through some work on impactability. I'm hoping some of you know a little bit about this, but I will go and race through some of the reasons why we came up with this techno buzzword. As my wonderful boss told me, it's a techno buzzword that's hard to define, trashes the English language and is made up of lots of I believe statements. Not that my one-to-one with him for my end of year appraisal went well, but it's always good to know that the one thing that really excites me makes my boss and many of the other people at the wonderful strategy unit laugh because they think it's made up. But I will try, and don't you smile, Simon Bourne, you're one of them. I will try my best today to explain to you why impactability is a thing and some of the evidence behind it, and also some of the work that we're doing right now with NHS England on impactability, which is where the incredibly, he's as handsome as he is great at machine learning. We have Santosh for that, and then Jack, who's a health economist extraordinaire, especially now in allocative efficiency when we talk about the work that he's doing nationally on that work too. So I will just share my screen. So first of all, it's how impactability is involved with population health management. And of course, because I'm a shameless narcissist and self-promoter, this is a quote from one of our papers. But the challenge for population health management, I think, is to identify which interventions are most likely to succeed for an individual based on the wider circumstances, and we'll talk about wider determinants as well in a bit, and how these interventions may be delivered in a way that's most likely to achieve a positive outcome. Yeah. And of course, we've been trying to do this for years. This hasn't, this isn't something that's just come out of the blue, but some of the tools we've been using in the past have struggled to get there. And this is hopefully where we can try to point out how this happens. And one of the tools, something that you guys as analysts and guys in the local authorities, and I saw we had friends from public health as well as analysts will know very well, is risk stratification. You would have seen these wonderful pyramids, certainly popularized by Kaiser Permanente back in the noughties. And again, if you were a boss and showed any interest in risk stratification, Kaiser would whisk you off to California. You won't believe how many bosses claimed that they were very interested in risk stratification. Off they went to 1,000 Oaks in California and to see the Pima Indians and to do a load of work on risk strat. Being a miserable, lowly analyst, I never went to go, not that I'm bitter and twisted every day. But anyway, here we have a risk pyramid. And as you know, we have our lowest risk at the bottom, going to the very high risk. And what we're looking at is that an event or an outcome that they're at risk of. Yes, so it may be deterioration, it may be time in hospital, it may be a heart attack or a stroke. So why do we risk stratify? So it helps us better understand people within our segments, and we can, if we've segmented our population or the entire population who are at greatest risk of having that significant health event or deterioration. It's used often to support the targeting of interventions. So maybe it's people who've been to hospital. So when they leave, do we make sure that they have a great discharge program to make sure they don't come back? And it's to align a healthcare to an individual's health needs based on their risk. And of course, this has to be conducted at an individual level, or normally conducted at an individual level. Otherwise, there's this, you get this kind of, homogenous kind of blob, and rather than, and care isn't individualized. So 3 main ways of doing risk stratification in the NHS. So there's clinical perspective, and any of us who've worked in hospitals, you'll know that the clinicians will often say they know who's coming into A&E, they know who's at risk of an event. Next, we have threshold modeling, and this is very, very popular and still used a lot at the moment. And this is where we have kind of rules around the number of hospital admissions or the number of diseases, and we can create frailty indices and kind of go from there. So this idea of, like Chad's VAS score for atrial fibrillation, and there are other Hasbled score for risk of bleeding, etc. So lots of these things which actually just take into account, are you over 65? Have you ever had a hospital admissions? Do you have diabetes? These are basically binary kind of outcomes on this threshold modeling, which inform your risk of an event. And finally, the sexy stuff. And now, if you want to go to America, well, before COVID hit, you show some interest in machine learning, AI, or those kind of predictive algorithms. They're the guys who would whisk you away. And this is where predictive modeling using multiple regression, if you're old like me, or machine learning is very de rigueur. So predictive models are recommended because they are the most accurate. To be fair, our clinical friends are absolutely appalling at guessing who will be coming in and looking across the population. One, because they have a limited view of who they see, because it's the people who keep coming back in. But of course, they don't have the information that you guys have to hand if you've got the right data. So examples of predictive modeling tools are these are some oldies and goodies. So patients at risk of rehospitalization, so PAR. The combined predictive model, and PAR basically used SUS data. Combined predictive model added a little bit of primary care data to that SUS data. So it's the same kind of group who developed that, but this time funded by the King's Fund. But then there are commercially available ones. So I know many of the CSUs, and I know Mids and Lancs CSU have adjusted clinical groups. So the ACG, which is developed by Johns Hopkins, and there's Q admissions by ClinRisk. So a couple of these you have to pay for, so ACG and Q admissions. Some of them are free, PAR and combined, and of course can be tailored by you guys on your patch to better understand the risk and be trained on your data. But all of these models are reasonably similar in terms of predictive performance, just that some are free and some are expensive. So, but a key bit here is all because people are at high risk doesn't mean that they've got the highest chance of benefit. And so when I first started doing this, you assume the person most likely to have the heart attack is the person most likely to be able to avoid that heart attack. That's not true. So the key to success of risk strat is to ensure that high risk individuals are not conflated with those most likely to benefit. And there's loads of evidence to show this. These are highly separated groups and kind of going forwards. So this is where impactability starts to come in. So this is the idea of why do these risk models, where we are very good at predicting risk, we're very good at predicting who will be in A&E or who will come to hospital, but we can't predict, or we've struggled to predict, people who are amenable to change, who are coming to A&E, but we can stop them with the appropriate intervention. So as always with these things, you've got to look at the evidence and the literature, and there's nothing more dull than a systematic literature review, I'm afraid. But we have to do these things. I mean, it's the most painful part of certainly last year and the year before. But it's very busy. I will go through all of these boxes in the next one, but just to say this is all the information on one slide, and I'm sure Rachel can share the slides and all the references afterwards, and as it's all fully referenced. But what I'm trying to show in this slide, things basically grouped into 3 areas. So we had health conditions amenable to preventative care, and health needs and health needs analysis or health gap analysis. So this is the idea of, are they diseases that we can work with? Are there simple gaps in care we can close? Next, with these kind of more psychological approaches and behavioural approaches, looking at propensity to succeed and behavioural response models. And finally, how healthcare professionals who may be terrible at predicting who may be coming into hospital are extremely good, or could be potentially good, at assessing someone's individual's likelihood to benefit, coming with the biases that individuals bring with them. So 3 big areas that we'll kind of go to now. And to say I will kind of go through these at a reasonable pace, but then we can have some questions at the end. So health conditions amenable to preventative care. So ambulatory care sensitive conditions are a great one. So you can look at those. So good old things like COPD, which is part of the 20+5 and still part of the long-term plan. So there's lots of data available to identify these specific, specific cases. We may be able to reduce inequalities in these preventable health conditions as they're more common in deprived communities. And there's lots of data potentially available to look for things like a missed test or a missed immunization or treatment, people who haven't had those gaps. And then, of course, what we can do is count up those gaps in care. When someone should have had a diabetic foot exam, the eyes tested, they should have picked up 13 boxes of drugs, but only picked up 12 in a year or 10. How can we identify those gaps in care and then start to weight those gaps? What's more important? The person with a very high risk of having a stroke not being offered an anticoagulant that could stop that stroke, or a controlled diabetic, someone with great HbA1c who just happens to have missed their foot exam for a month. You can then start to look at those gaps, both the gaps in care, but one may be higher weighted because of the outcome than another, and you can start to weight those gaps and then identify patients for this. One of the key bits that this doesn't address is those psychological and behavioural variables. Because they have had those gaps, there may be reasons that those gaps are there that aren't in the data, or these people may not care and may not engage with those gaps and when you try to close them or the intervention. So propensity to succeed models and behavioural response models, as you might suspect, are much more about how the patient will engage with care. So identifying groups or individuals where an intervention is likely to benefit them, and hopefully therefore designed to avoid wasting resources. So this is excellent potentially in integrated care boards or systems. So this is where primary care networks can have a huge role, because they really understand the communities, and they may understand or better understand what interventions would work for an individual based on their knowledge of knowing that person, or on the cultures and where those people live. Care planning strategies that can be then optimized based on previous responses. How have they responded to a previous intervention? They engage with the healthcare, they engage with the education and the diet. Are they then great are they then potentially prioritized for another kind of intervention similar to that, where other people would have a different thing. So models would be enhanced if we better understood some of the educational, behavioral and psychological and those socioeconomic data. Of course, we have things like Acorn and Mosaic, which could help with some of the social and economic. Of course, the education and behavioral we don't always have, but there are ways, and of course, when we integrate data, to be able to gather this going forwards. And of course, we need to make sure that this data is consistently recorded. And then healthcare professionals' assessment of likelihood to benefit. So we then had a look at this. So of course, what you're really seeing here is the healthcare professional is, because they have that real-time interaction, they're able to close some of those gaps in the data which we don't have, in our data sets. So they may be able to better identify through questioning with the patient those kind of key areas to be able to help better design or better choose the intervention for that patient. Of course, highly resource intensive and expensive compared to amazing analysts going off and doing the work, but on big data sets, relies on the quality and openness, and of course may perpetuate biases and prejudices, because we know that there are a lot of prejudices on people saying, oh, well, we think they will be better at responding to this than this person because of because I think that they're white and middle class, or because they're they may have alcohol or substance abuse problems, they will be less likely to engage, so I don't offer them. So there's loads of these things in the evidence that show that we may perpetuate biases if we just let them choose. So that was the evidence behind it. But of course, why trust international experts when we have great experts at home? What do they think? So we did some workshops to ask people what they think, and I will be asking you, because who knows better, not these people that we invited to these workshops, unless of course we invited you to those workshops, but we will ask you guys right here, right now, some of the key questions from these impactability workshops. But we did ask some experts. So Geraint Lewis, Martin Barnsley, Adam Stevenson, Theo, Jason, Jessica, Gary Hudson before he left, and then and people like Matt Kearney. So asking them for some expert directions to build the workshops. We then built 2 workshops. One asking them about whether impacted modelling is currently used and what they thought about it, and then the second workshop based on which models should we start to build as we move to the future. We had lots of different people there from different organisations, all hopefully reflected here, including retired. I'm guessing this is Martin Barnsley because he has retired, but there were other people invited along. So hopefully we had a nice snapshot of people across the NHS and the healthcare sector, so including our friends from local authority, public health and beyond. So the first question, and I think we have a Menti for this, is how would you define impactability? From what we've just raced through in the last 10 minutes, how would you define impactability? Is that going up on, I can't see the Menti on my screen, so I'm hoping all the magic is happening.
Yeah, the magic is happening. I can share my screen, but I think people are thinking is what I think. So I'll share my screen and see if anybody is going to have a go at defining impactability. Go on, guys, it's anonymous. We don't know who you are. Just give it a shot. I'll share my screen.
And it'd be really interesting to see if your results, yes. To be fair, I wish I'd kind of registered this. I could have been earning, if I earned a penny for every time I said impactability and other people now said it, I think I would be well off. Excellent. So we won't dwell on this and force you to. But I love the idea of when we're looking at likelihood of success, and being able to identify people at risk. These are the potential to make a positive desired change. These are the kind of things, and that impactability is in my head. So it's this idea that it's very much related to identifying the subset of at-risk patients for whom preventative care is expected to be successful. Yeah, it's that kind of thing. It's so it's better understanding what will work for them rather than what we think will work for them based off of this kind of bell-shaped curve. We know that lots of people interact differently, so we can move on to the next slide. Can I share again? Share. Sorry. Cool. And so, funnily enough, in the workshops, the people all came up with some of those similar ones, and I'd be love to keep that Menti, by the way, Rachel. I really would, to be able to see. But it was clear from workshops, impactability modelling concept wasn't clearly understood, and it was a struggle for people to come up with some consensus. But what they did come up with was the kind of quote or the definition created by Geraint, who we can blame for using impactability because he brought it back from the US after he did his Harkness Fellowship. He was the one who kind of coined it because the Americans were using it in the insurance sector. But it's this idea to identify the subset of at-risk patients for whom preventive care is expected to be successful. So hopefully, and what we're trying to say in this chart is not saying that no one gets excluded. What we're trying to do is find out what intervention works best. So everyone gets an intervention if it's appropriate. Of course, some people may be receiving all of the interventions already, so therefore they don't need any more interventions. Any more interventions could cause triple fail events. But what we're saying is that people may be amenable to a certain type of intervention, and that doesn't mean only the at-risk patients, because they may share something different in common: their behaviours, their beliefs, their social and economic circumstances, the disease state. So how do we look at those? So different people may be amenable to different interventions across the strata. So the next question: are there any benefits? What could the benefits be if we got this right, and if we could find, when we risk stratified people most amenable to change, and to be able to better target the interventions that link to them? And I'll trust the magic to you again, Rachel. So one I will throw out there will be a reduction in triple fail events, where we're duplicating tests, so it's, just like the triple aim, the triple fail, it costs more for the system. It's could cause harm to the patient because they're having unnecessary tests that could lead to some kind of harm. And of course, it's a worse experience for the patient if you're having repeated tests or a repeated or think that you're at risk of something when you're not at risk. And these are excellent. So yes, so there is a whole element around money saving and targeting limited resources and reducing costs. There is hopefully a key bit around better outcomes and reduced harm, and looking at resources and positive outcomes. Jack knows a lot about allocative efficiency, and we'll be talking about it at a system level in a second. But this is, again, a great way to look at how we allocate resources most efficiently. So, knowing that we're running out of time, I will be quick. So, the benefits include patient benefits. There could be time saved for healthcare professionals because they don't have to repeat things. And impactability analysis will hopefully allow the incorporation of this wider determinants data. And as we know, 80% of your health outcome comes from these modifiable wider determinants. So your environment, your health behaviors, and your socioeconomic kind of situation. So these make a huge difference. And so being able to include those two mean that hopefully we'll be able to get better outcomes for patients. Of course, increased efficiency that you guys have mentioned, and avoiding triple fail events, which will be very important too. And here's a lovely chart that was made by the lovely Matt Greck for one of our papers. But the idea of it's an increased chance, because he's so positive. So rather than triple fail, he likes to say an increased chance of hitting the triple aim, of being able to bridge that impactability gap, this idea of better understanding of the patient to then case find them and then offer the appropriate intervention. But you're all pragmatists, and as analysts who have been working on this kind of data, you know that there may also be challenges. What are the challenges for impactability? What have we got to be wary of as we kind of move forwards? Yes. So the idea of one of the things is how we measure success in some of this, and certainly if we're looking at the qualitative aspect of how people enjoy and engage with their care and what they think about utility. And yes, we've got to be very careful about basically ending up with excluding certain individuals. And of course, what we're trying to say is that people don't get care taken away from them. Everyone still gets standard care, but do we better tailor care? Because that standard care works for the vast majority, but are there different people who need additional care that we can tailor it forward? But absolutely, yes, we can't abandon patients who aren't impactable. As I say, we've got to make sure that they get some treatment, but by impactable, we mean, can we tailor the resources that they get so they don't just get the standard? Absolutely, the complexity of the patients will be different, and of course bias with all these things. If we're using data and getting people involved, there's a huge risk of that. So as we race through, so challenges, many of the things that you already mentioned: timeliness of data, can we actually do anything different? Data biases, demonstrating value, return on investment. And but we asked this group, where should we go? If we're going to build a model, and NHS England's going to build a model, what should they have a look at? And then what they chose is a top-down model. And just to give Santosh a bit of a heads up, because he will be talking on the next slide about the model that he is working with or working on and building right now, that looking at an ambulatory care sensitive condition. And in this case, I think it may be all ambulatory care sensitive conditions, or a bottom-up approach where we choose interventions and find the people most likely to succeed. So these were the advice from the working groups, these workshops, and from NHS England. So we are currently in the process of building two models. One, which is a bottom-up approach, which is one that I'm leading, which I'm using, which is looking at ambulatory care sensitive condition, CAPD, and it's looking at gaps in care, and it's looking at how we can close those gaps, but also the risk of progression to multi-morbidity. But Santosh will give you a little bit more detail now on the model that he's building. And so just say next slide, please, Santosh, and I will press the magic button. Unless Santosh has run off.
Yeah. Thanks, Andy, for giving this very wonderful introduction about the impactability models. So I'm building here the ACSC prediction model. So the ACSC are the condition where the effective community care and the case management can help to prevent the need for the hospitalization of the admissions. So that's why we're trying to build prediction for these ACSCs. So in particular, while building this model, we are taking a typical machine learning approach to build this model. So it's involved like three very important and crucial steps. The first one is like the problem formulation. How we gonna define the ACSCs? What is the objective we are trying to predict? And what are the other supportive variables or the data there? And then the second one is the data preparation, so there are a lot many examples or data is available there. So, but there's ethical problems are there. So we need to understand like how we can really access to those data and how we can extract those data from the sources. And then very third one is like the understanding data, which is, you can also say, the exploratory data analysis, which is very important steps before you are building any kind of model. Because if you are not understand your model, if you are not understand your data, what data is saying, you will not able to build a better model. So we are particularly looking into it, the data quality and the feasibility and the exploration of the variables and the exploring of the inequalities in the data. So, and that the fourth one is the data processing, which we are doing feature selection, feature engineering, engineering task. And then fifth one is we are trying to build a model on these selecting variables on the ACSC conditions. And then finally, we have planned to deploy our model into a secure environment where it can be like a risk stratification tool, or it can be a simple report. Yeah, please, next slide, please, Andy. Maybe I can, yeah. So as I said, like we are give the definition of like what is this ACSC conditions are. So what we are trying to do, we have this data set which is called the NCDR data sets, and we are trying to propose to predict hospital admission using the machine learning, using those steps which I explained previously. And the prediction is to make like each patient initially admission episode for 1 year from having the record of the ACSCs. And this prediction will be like the various patient information, risk of ACSC, and known as a good prediction of admission, as well as independent variable, which include their like variables like age, gender, demographic information, their lifestyle variable, clinical variables, and the known disease and medication of, and also the laboratory test or and the results. And the variety of different matrices to evaluate this model performance is like basically we are trying to evaluate using the predicting accuracy, ROC, decision operating curve, specificity, and interpretability, and bias and generalizability of data analysis of these model. But the most important part is here, like we are trying to do not only build a good model, but at the same time, we are trying to build a model which is not biased in terms of model building and model prediction. Please, next slide, Mandy. So as I said, the bias is a very important part when you are building a model. This is a very good resource, and that's why we mentioned here. This is a very good paper. You can understand like how the bias and are incorporated into the machine learning phases. So the bias is not only available into the model which you are building, or it's not only available into data which you are collecting. The bias is at every phase of the model. It can be like when you are generating, you are accessing your data, you are interpreting your data. It can also be in when you are training your model, when you are evaluating your model. So there's a lot many definition of the biases. It's not a very simple definition like your data has your bias. For example, as a human, we also have a bias of inside, and when we are building some model, we are doing some coding, we can introduce that bias into the model. So that's why we are very focused on the bias. Like we should focus on the bias in the machine learning when you are working, especially in the healthcare domain. So the bias can be like in three different mainly the phases. It can be like introduced during the historical collection of the data, and the specification bias, which can be like when you are generating your data, and also it can be like when you are evaluation of the model, when you are evaluating the model. For example, if we are more focused on the specificity rather than the sensitivity, then it can be a problem. So rather than simply guarding against these harmful passively biases, machine learning system should be used the proactive advanced health equality, and the principle of distributing justice must be incorporated into the machine learning design, and also the model design, deployment, and the evaluation. So again, the bias is not just, don't think the bias is available just in your data. It is everywhere, every phase of when you are building a predictive model. Next slide, please. Yeah. So how we can evaluate and how we can distribute justice option in this machine learning thing, the biases. So it can be like the equal outcomes, which can be referred to assure that the protected group have an equal benefit in terms of patient outcome from the deployment of machine learning algorithms. And the equal performance is like assurance that the model is equally accurate for the patient in the protected and the non-protective groups. And the last one is the equal allocation that ensure that the resource and the proportionally allocated to patient in the protective group. So this all happen when we can build a model which is not only giving the better performance, but a model which should be like fair enough to distribute these resources or doing this predictions. Thank you. This was for me quickly. Any questions?
Thank you ever so much, Santosh. I'm sorry we had to race through at the end there, and maybe, again, if people are more interested in the detail of what Santosh is doing and say, I'm creating a competing risks model for COPD, and say we could go into that in much more detail on another day, because the exciting Jack and allocative efficiency stuff has to come. But if there are any questions, you can let us know. Just email us, and we can put that in the chat, or and we can put it on Menti, and we're very happy to help if we can.
Can we just take this question from Stephen?
Oh yes.
Yeah. Just one question.
Hi, Santosh and Andy. Thanks for the presentation. I was following it all the way through. I thought I grasped it all, but then I got a bit confused on Santosh's slide when he was describing the impactability model, because what you seem to be the description of that model seemed to be a description of you trying to predict the risk of somebody having a subsequent admission, which seems like a risk model to me. Whereas the impactability models, as I'd understood it from your earlier slides, were about trying to find those people who might benefit from an intervention. But I didn't see what the intervention was you were trying to test your impactability against. What's the intervention that you're looking at? Have I got confused there? Is it just me?
No, yeah, that's correct. So first, what we are trying to do, we are trying to build a simple predictive model. And we know like the predictive model can be useful to identify a people at a high risk of an unplanned hospital. Although we already know that there are some of high risk patient identify of these prediction model may not be like manageable to the preventive care. And once we will see like how much is the difference there, then we're gonna build another model using this NCDR data, which can aim to identify the subset of at high risk patient for whom preventive care is expected to be successful.
And what's the form of preventative care that you're testing your impactability model against? Particularly, what's the preventative intervention that you're tuning your impactability model to?
Yeah, so we are tuning both the model same time.
Okay, maybe I'll follow up afterwards rather than take up more of time. Jack's got presentation.
Yeah. No, Steve. No, it's a really good point, and I think that what NHSE asked for was a model that could predict the first attendance for an ambulatory care sensitive condition admission, and then what factors could ameliorate, what could prevent that going forwards as we kind of go. And just to say, on the COPD model, we're going through all of the interventions in NICE, so all of those treatments that have been evidence-based as part of that model. Again, I say obviously Santosh and the guys are doing a lot of work helping going forward. But I'm so sorry, Jack. We will pass over to you.
No worries at all. It was all very interesting. Yeah. Hello, everyone. So I'm Jack, health economist, and I'm going to speak to you a bit about allocative efficiency in the NHS and a piece of work that we're doing alongside the Midlands Decision Support Network and some of you guys in your ICSs. I think I can see some people from Coventry and Northants on the call. So hello. So I'm going to say, firstly, what is allocative efficiency? Then give a quick overview of a method that you guys can use to think about allocative efficiency when you're supporting people with decisions. And then if there's time, briefly describe a sort of program of work that we're planning in COPD on allocative efficiency. So firstly, what is allocative efficiency? In economics speak, it's where marginal social cost is equal to marginal social benefit. And what that means for us in healthcare is the point where you get the most health for the available funds that you have. And this is my attempt to visualize allocative efficiency. So on the right, you've got health. So the aim is to get as big a heart as possible. And on the left, you've got the various inputs that we can tweak to maximize health. So the idea being you twiddle the dials on the left-hand side in order to get as big a heart as possible. That's the sort of basic principle of allocative efficiency. So this contrasts with technical efficiency, which is sort of the primary example of efficiency used in healthcare. So technical efficiency is about doing things right. It's about producing a good or service for as little input or resource as possible. And I'm sure you guys will all recognize this from things like reducing the length of stay following an operation, which allow you to do more operations for less cost, or by shifting care to less expensive settings. So perhaps a preoperative assessment, instead of seeing a consultant surgeon, you would see a nurse specialist, who are all amazing people, but cost less to the NHS than a consultant surgeon. And this is very important that we do things for most efficiently, most technically efficient. But there are some quirks of technical efficiency. So the first is the Jevons paradox. So Jevons was an economist in the 19th century who realized that when a more efficient steam engine was produced, demand for coal increased, which seems counterintuitive. If you can use less coal in your steam engine, surely demand for coal should decrease. But he found the opposite, and that the increasing efficiency with which a resource is used increases the rate of consumption of that resource. And that will mainly be because you by increasing supply, you reduce the cost, and therefore demand will go up because you can do things cheaper. And this is sort of applicable to healthcare in something called Romer's law. So he was a professor at UCLA who said in an insured population, a hospital bed built is a hospital bed filled. So this is, i.e., the more hospital beds you build, the easier it is, the more supply there is, the easier it is for a doctor to say, well, go to a hospital bed, the more hospital beds you'll use. And there's been more recent studies that have shown this to be the case in ICU in ICUs in the NHS, and there's a reference here. So whilst technical efficiency is really important, what you can end up doing is doing the wrong things right, if that makes sense. Whereas allocative efficiency is about doing the right things. So i.e., a classic example of this that we're all familiar with is instead of waiting for someone to develop a chronic illness or get an acute episode, which is very resource intensive, you can spend some money on preventative medicine, stop them getting that chronic illness, and making them live a happier, more healthy life. So it's important that we not only think about technical efficiency, but also about allocative efficiency. And very quickly, I think, Rachel, we've got a Menti for this too. I don't know. If not, people shout out. If anyone's got any examples, perhaps, between this sort of difference between technical and allocative efficiency that they can think of. This might be an unfair question after an hour of complex bits.
just trying out different ways of presenting. Can you
Oh.
see me as well as the
Yes.
screen? I mean,
Yeah,
I'm not saying that's a great thing, you know, just look at me. I was just trying these things out. Oh, and I thought, what better time to try out one of our wonderful huddles. But we do have someone saying something.
Oh, yes.
I now don't like seeing me. I don't know how to get it off now.
Well, there are worse things to see, Rachel.
He means me, Rachel.
I know.
Yes, here we go. These are some really good examples, and I like the operation as a success, but the patient died. I think, well, I don't like that happens, but that's a good example. And you can think of, you know, expensive hip operations or operations on frail people. Yeah, cool. These are some really good examples. Cool. Yeah, so gonna moving swiftly on. So how this principle is all well and good, but how do we think about this in healthcare? So one thing that we're promoting in the health economics unit is the STAR approach. So STAR stands for socio-technical allocation of resources. It was pioneered by the Health Foundation and the London School of Economics, I think in the noughties. And this is broadly the process that it involves. So in the circles, you've got the technical bits. So you identify interventions for a particular care pathway or in a particular budget. You then value those interventions, and there's various ways that you can do this. So one that I hope most people will be familiar with is the QALY, or quality adjusted life year. You then do some number crunching, you calculate the cost of those interventions, you identify the population that will you can target those interventions at, and then you do something called program budgeting and marginal analysis. So that's the technical bit of the process, and I'm sure everyone on this call can do those bits with their eyes closed. It's some very simple maths and some data you'll all be familiar with using every day. But the key is the socio bit. So what you could do is you could take your sort of output, your program budgeting and marginal analysis, give it to a decision maker and go, well, decide what to do. Instead, we're doing the STAR approach uses something called decision conferences. And these are used in lots of different areas, as some people might be familiar with multiple criteria decision making. There's also the Delphi method, consensus conferences, lots of different names for these. Essentially, this involves getting all of the relevant stakeholders in a room and discussing the way forward and reaching a consensus about what to do. And in STAR, this is not just about getting you know, your sort of NHS finance directors in a room. It's about involving everyone in the health system. So you guys in local authorities, perhaps also our friends in who work for charities that help make people healthier and keep them healthy. And also even our friends in the private sector who deliver NHS services, perhaps. And by getting all these people in a room, you can reach a consensus about the way forward. And this is an example of the sort of output, the technical output of STAR that you can use in your conferences. If anyone's interested, I can share the maths behind this. It's very simple, but what you can see is on the x-axis you've got spend, and on the y-axis you've got population health gain or value, and the slope of the hypotenuse shows how much value for money you get for these interventions. So what you can see here is for the Falls pathway, lots of money goes into hospital admissions, but actually some of the value, or most of the value, is generated earlier on in the pathway. So that's through, you know, some of the downstream interventions. And I know what you're thinking. This is, everyone knows this. We all work in the NHS. Prevention is better than cure. So what is different about this? The difference is, one, this gives you a very visual and easy to interpret view of that principle, but also during your decision conferences, you can manipulate these triangles to start going, well, actually, if we spend a bit of money, more money on medication review, that would give us this more population health benefit. In a really simple and easy way for everyone to interpret. You don't need a PhD in health economics to understand these concepts. So that's very broadly STAR methodology. We're planning a big program of work working with 4 ICSs and the strategy unit and the Midlands Decision Support Network to embed allocative efficiency and STAR in funding processes for COPD. And why COPD? It's a very resource intensive large pathway that has a large disease burden, which makes it a really good exemplar disease for STAR, not a good disease, but an exemplar disease for STAR. And also because a lot of the determinants for COPD lie outside of the health system, it's a really good example of where a population health approach can be of benefit. This is broadly what it will look like. So we'll be running these decision conferences with 4 ICSs in the Midlands. One thing we'll also be doing is an education program that will give you the skills and the ability to run STAR in your own ICS for your own pathways. So keep an eye out for that. That will become available to you guys some point this financial year. So there we go. So yeah, this is my email. If anyone wants to find out more, do get in touch. In the last couple of minutes, does anyone have any questions they'd like to ask?
There are a couple of questions. I'll just, not necessarily for you, but one definitely is. So I'll just share my screen. So what have we got? Okay, someone's asking which are the 4 ICSs that you're going to be working with for the COPD.
Yes. So it's Coventry, it's Coventry Place, not Coventry and Warwickshire ICS, Nottinghamshire, Birmingham and Solihull, and Northamptonshire are the 4, so the Midlands one.
Okay. There's a question for Santosh. Just quickly, which, if we've got time, which lifestyle variables have you been able to include in your model, Santosh? If are you still with us? Please.
He's so rock and roll. He's in the
Yeah, sorry.
He's at the after party already.
Yeah, so like few like their social status and also like their daily activities, food habits, and those kind of variables basically.
Okay. I guess sometimes it's about what data you can get to describe these things. So the first question is, I think, from somebody who wanted to ask it before but wasn't able to because we didn't allow her to. So this question, how do you cater for people in the population who haven't yet received COPD diagnosis? Tends to be quite a gap between the actual and the expected prevalence of COPD, which is probably why it was chosen.
Yes, and so just to say, in the model that we're building for COPD, there are a whole load of evidence-based symptoms that people will demonstrate and have in the data before they get a diagnosis of COPD. So there's some wonderful work done by Jenny Quint and others. So again, you can try and identify those. If this is about the predictive model, that's what we do. We're looking at. But then Jack's also doing a massive SLR looking at. Sorry, I'll shut up. You're here, Jack. You tell them.
Which one is this? The what I've
your wider determinants SLR.
Yeah, so we're doing an SLR as part of the STAR program to identify interventions that can have an effect on the wider determinants of COPD. So that's environmental factors, air pollution, pollution in the home, behavioural interventions, so physical activity, and then socio-economic determinants too. Yeah.
That's great. Thanks very much. The last point was around someone being interested in the practical details of the impactability models developed, but you don't have time to talk to that now, because guess what? It's 12 o'clock, and that means one thing. I have to press the button to say goodbye. But before I do, thanks ever so much for coming today, Andy, Jack, and Santosh. I really enjoyed the session. Sorry for all the stick early on, Andy. I can't say it's not going to happen again, because it is. And I'll just stop sharing so you can see me.
A huge thank you, Rachel, for inviting us. You know, we love to come along, and very happy to go through in detail, and maybe, you know, when's appropriate and when people are happy to go through Santosh's model, my model, in much greater detail for the analysts here. We are creating step-by-step guides as part of this, as part of the work for NHS England, as is Jack for his allocative efficiency work. And so the work that Santosh is leading, and Jack, there will be, you know, the whole point is that we lead the skills. We know that people on the call can do this stuff. It's just how can we make sure that they learn it, and we can share that. So yeah, very keen to share in the future.
Brilliant. Thanks very much, everybody. See you in a couple of weeks.
Cheers. Thank you. Bye-bye.
Okay, bye.